Hi, and welcome to today's Oxford Centre for Personalised Medicine Flash interview series, where we talk to individuals involved in personalised medicine in one way or another. Today, I'm honoured to be speaking to Professor Angus Clarke, Clinical Professor at the School of Medicine at Cardiff University. So hi, Angus. Thanks very much for taking the
Hi.
time to talk to me today. Would you mind starting off by telling me a bit more about yourself? So who you are, your journey, and your professional interests.
Okay, so I'm a clinical geneticist. I'm sort of I suppose at the senior end of towards the end of my career, I suppose. I'm sort of beginning to retire and step back from a few things. I started off, I suppose, as in pediatrics, and moved from that through one or two research jobs into specific pediatrically relevant genetic conditions, into genetics. And so I've developed an interest in different aspects of genetics over the last few decades. Yeah.
Fantastic. So if I say personalized medicine, what comes to mind to you?
I'm not very fond of that as a phrase, I suppose. I think it's a potentially sort of wolf in sheep's clothing, or potentially a bit misleading, because the word personalized makes it feel like warm, furry, cuddly. And I suppose I think I'm happier with words like individualized and stratified. And there certainly is a role for genetic testing that allows risk assessments and therapies and so on to be targeted, particularly to an individual, but I mean more often actually to groups. So particularly with tumours, there are different classes of tumour that would be identified. So someone hopefully then gets the most appropriate of the available treatments and so on. So yeah, but I would tend to avoid the word personalized as sometimes a bit misleading, and just sometimes distracting, because approaches to risk assessment and disease prevention, I think sometimes does benefit from genetic testing, but for a lot of disease prevention is often best approached through traditional public health measures, in terms of sort of air and water quality, diet, exercise, public transport, a range of different things, where genetic testing really plays little part. So I wouldn't want to overemphasize the role of genetics, despite working in genetics. I think one should be modest about where it's applicable. Yeah.
So you've got a broader interest in kind of the social and ethical aspects of genetic disease. Could you talk to us about what you see as the key societal and ethical implications in this field?
The fact of genetic disease and it being opened up over the last, progressively, particularly over the last couple of decades, then I think it really reinforces the need for a decent, so high quality National Health Service. Because if you don't have a decent national collective approach to genetic disease, then of course you end up in a world, say if healthcare is individualized, from a resource point of view, you end up with people who have massively unequal abilities to cope with the genetic inheritance that they have received from their parents. So you could get massive inequalities, and some people would be hugely disadvantaged. So I think the going down a North American healthcare model, well, to say North American, a US healthcare model, I think would be would be disastrous, and the development of genetics reinforces that. And so sort of, I'm very unhappy with the current, the last decade or more running down of the NHS. I think is a huge issue. And yeah, so that's one of the main things. I think with the current expansion of genomic services, I suppose there are quite a number of issues to think about. Perhaps the quality of the counselling that accompanies the delivery of genetic testing, I think, is a big issue for me, because well, this isn't just a question of the quality of the information giving. It's a question of the way it's framed and how people are helped to understand or to look at the potential impact on themselves and their family of genetic test results. And what you don't want is a world where people are given information and everyone's very enthusiastic about the genetic testing, and then when they get the results, it hits them very hard in a way that they've not had any preparation or warning about. And some types of genetic testing don't raise that issue very much, and are relatively straightforward, whereas others do. I mean, if I think of a current example where things are perhaps a bit difficult, and that might be, say, in the context of motor neuron disease. So it's not something that traditionally there has been very much clinical genetics involvement, in contrast to other neurodegenerative conditions like Huntington's disease, where clinical genetics has been involved for a long time with many of the families involved. But motor neuron disease has been much more seen as a sporadic condition that is dealt with largely by neurology, and there are sort of treatments being developed so that there are occasional clinical trials for rare subtypes of motor neuron disease. So if you offer someone genetic testing for motor neuron disease and say, well, there are treatments being developed for this, then, and people say yes and don't think much more about it, then you're really potentially walking into a great minefield, because the fact that there are occasional clinical trials is a long way from saying that there is an established treatment. And if the family has not had or other family members have not been informed about what's going on, and they are suddenly put, if their affected relative is found to have a change in one of the relevant genes, then other family members might find that they are at high 50% risk of also inheriting this condition, for which perhaps there is no treatment yet, and perhaps not even any clinical trials. So for the patient then to have to talk to their family members, well, they have to make a decision either to talk or not to talk. And when they are themselves ill, this is very difficult, I think. So that would just be an example of a disease context where just going straight ahead with genetic testing immediately without spending time supporting the individual and their communication with other family members, I think would be very difficult and unwise. So this is where the enthusiasm with the ability to do testing could lead people to run away with that side of it and not pay enough attention to the talk that has to go on around it.
And so does this link into your current ESRC funded project on patient decision making with genetic testing?
We're still writing up an ESRC, or the output from an ESRC grant about genetic testing. That project was about really what's going on for patients and the families around them while they go through the process of genetic testing, and particularly in the context where the genetic testing is not guided by strong medical recommendation. So there'll be lots of times where one can make a fairly straightforward recommendation to have testing if it leads into good and effective treatment for the patient and maybe at-risk family members. And there are, quite a few circumstances where that applies. But if you're talking about something where there's no effective treatment, or if you're talking about prenatal testing, where the decisions are often much more personal rather than with people being told what to do or with clear recommendations being made by the practitioners, then there are a lot of things that will be going on for people. So with things, say, if we think of antenatal screening and prenatal diagnosis for different conditions, there might be, people will be very influenced, and some of our data shows this. People can be very influenced, say, by their experiences of disability, either in the family or in those around them, in their communities. They can be influenced by people who give them the benefit of their wisdom, so tell them what to do, and they can be influenced, one way or the other. I mean, people can be antagonized by what perhaps well-meaning friends and family sort of tell them to do. So there are a lot of things about people's lives that shape what decisions they make, both about prenatal testing and predictive testing too. That project was sort of looking at that. So partly looking at what goes on in consultations and what surfaces in consultations, and partly looking backwards, so getting people to reflect after a decision has been made and acted on, but also gathering information, asking people to keep diaries of their decision making and what's going on for them during sometimes the process of some months while the decision might be made. And I think that this diary component, and sometimes audio logs that then people have kept on phones rather than actually writing a diary. Maybe it's a bit like Big Brother and some of the reality TV things, where people go off and confess in odd moments of quiet, and occasionally a couple of instances we've had of family conversations being recorded, and I think they have been particularly insightful, or given insight into the intensity and groundedness of the thoughts that people are having. And we professionals might be thinking about the influence we're having on families in the way we present information and talk about it, but the patients and their close family members are doing exactly the same, and they're thinking, well, what did he mean when he said this? And okay, I know he said it's up to us, but what does he really, or she really think we ought to do. And, you know, we're trying to interpret them and they're trying to interpret us in sometimes very sophisticated ways. And I think I think it's a great training resource, actually, for people learning about genetic disease and genetic counselling to get some sort of insight into what is going on when we're not there. Yeah.
Fantastic. So I guess my next question would then be, how important, particularly as we move kind of towards more, as you say, individualized medicine, how important do you think it is that clinicians need to consider more broadly how someone's medical journey fits into their way of life? So maybe patients feeling more in control of their life and their condition, the decisions that are being made.
This brings me back to the disadvantage even of words like individualized medicine, because there are a lot of the health-related behaviours, if you like, where we know that usually, anyway, people being guided by the results of genetic tests about their predispositions to illness actually have very little effect. And I think there is a real danger of us being distracted by all this talk away from public health measures that either are or could probably be very effective, and many of which have not really been given a decent shot. So, you know, in terms of guiding people to eat healthily, or to travel, or to sort of exercise more. I mean, there are public health steps that can be taken to help cycling, clearly. And Britain has been, if you compare cycleways in, you know, plenty of European countries with what we have in Britain, I mean, it's pitiful. People are not helped. There might be lanes marked on roads now again, but very little separation of cycles from traffic, and you know, so cyclists are breathing in diesel fumes all the time and at risk of serious head injuries and broken limbs. So you know, they're very vulnerable. And if we think about food, you know, the idea of taxing unhealthy foods has come up, and there's been a little bit of, well, certainly talk and perhaps even a little bit of progress about that. But the idea of subsidizing healthier foods by taxing the unhealthier food, I think really hasn't had a decent shot in Britain. So the idea that, you know, we are in control of our health and our lives when many of the factors that influence our health are not under our control, whether that's through poverty or quality of water, air quality, safety in transport, things like that. I think we really need to be trying a lot harder at these collective public health measures.
Mm-hmm. Yeah, that makes absolute sense. So I also believe that you have had important roles contributing to the work of patient support organisations for specific genetic disorders. So what do these organisations actually do, and why have you felt that it's really important to be involved in these groups?
Yeah, I suppose I'm particularly involved with two patient organisations, maybe a little bit more with one or two others, but the two I'm mostly involved with would be Brett UK, which is a family support group for Rett syndrome, which is a disorder that causes sort of profound neurodevelopmental problems in young girls almost exclusively, and the group called Ectodermal Dysplasia UK, and that's a condition that, well, it's not one condition, it's many conditions, but much the commonest of the conditions affects boys, and they are unable to produce normal amounts of sweat, and they have few teeth and little hair, and those might be more cosmetic, but the inability to sweat causes major lifestyle changes that it forces on them. So there are lots of activities that are difficult and environments that are difficult for them, and they're also prone to chest infections because they don't make much mucus in the airways. So working with those family groups, it's I think it's a very natural thing for someone who's been involved with patients and families with such conditions to want to support the families. And so it's very much, so I would see that the role I've had as very much being trying to provide the support that the families and the family group ask for, and that will often be maybe a coordinating role with other professionals, trying to make sure that families get access to the range of professionals they might need. And sometimes it can involve setting up clinics, maybe multidisciplinary clinics that help families sort of see a number of relevant professionals on the same day. And it can involve helping families who want to contribute to research to do so, where that's possible, where there's a useful project going on. And yeah, so those are probably the main roles, but it's very much, I think, led by the support groups in terms of them seeing, or them being clear about just what support from professionals they want, and then trying to help, then either providing that or helping to coordinate that from other professionals. Yeah.
Brilliant, thank you. So finally then, looking forward, where do you see the field of medicine going in the next decade or so, in particular around the work that you do? What challenges do you foresee, and how might we overcome them? I guess it's the big question, isn't it?
Yeah. Oh, goodness me. I think in the context of genetics and genomics, and then I'd say that one of the areas that causes me, well, not sleepless nights, because that would be unfair, but causes me concern is about justice and the issues of justice around access to genetic services, and some of the potential sort of not so good effects of introducing genetic testing. So, and there's obviously questions I referred to earlier about having a decent NHS, but there's also say areas where the too ready application of genetic testing could put a lot of people at a disadvantage. So if we think about, say, predisposition to psychiatric illness, so mental illness, and more generally actually about studies of the genetic basis or the genetic influences on intelligence and behavior and personality and so on. So one can see that these are not, so mental illness and intelligence and personality and their problems are not things that have a hugely deterministic genetic basis. I mean, so there are, well, I should qualify that by saying that if I'm talking about intelligence, then I'm talking about here intelligence within the normal range or within the usual range. I think, say, like as with Rett syndrome, there you have something that is genetically determined and is a problem in a gene that has a profound effect on intelligence, communication, and brain function. But once we get away from that sort of, really severe and substantial problem, then if we look at genetic basis of IQ within the normal range, or of personality and these other things, and predisposition to mental illness, then we're not talking about genetic variants that have huge and deterministic effects. We're talking about interactions between multiple factors and the environment. And if you have a genetic test for intelligence in some form, sometimes it's talked about educational attainment or duration of education. These are factors, these are measures of, or they serve as measures of IQ. And if people are already discriminating or choosing between embryos in the lab which to implant on the basis of the likely range of IQ associated with the genes in that embryo. So that's available privately, I gather, in California and perhaps elsewhere in the States and perhaps elsewhere in the world. But if you test individuals who are here for their predisposition to IQ, then one can see that being open to all sorts of abuse in terms of selection for education and careers, and just modifying people's expectations of a child in what could be a very unhelpful way. If you have two siblings in a family and one of them is predicted to have a somewhat lower IQ, you can see that the investment in that child's education and development might be a bit less, and then you get into a self-fulfilling prophecy situation, and that could be true within a family, but also it could be very true between families or larger groups. So you can see, particularly as the genetic basis of these traits is much better worked out in white people of Northwest European ancestry than it is in other groups around the world, then you can see it being used to reinforce racial discrimination and disadvantage. But I mean, even within people of white Northwest European ancestry, even amongst them, these effects just within families or communities could be very unhelpful and stigmatizing and discriminatory. So I think these questions of social justice around the application of genetics, I think is something that I think we, as a community of people working in genetics, we need to focus rather more on that.
Great. Thank you very much for your time. Do you got any final comments that you want to make?
Actually, one of the things that I've not mentioned, and I not very much, I think is the war with hype. So that's something else, like the questions of social justice. I think there are a lot of claims made about research findings and how useful they are and immediately applicable and so on, that exaggerate benefits or overpromise what can be delivered. And some of that comes from people who have a vested interest, so either reputationally or commercially have a vested interest in a particular bit of research. But it's not all that. Some of it is just straightforward over-enthusiasm. But whatever the underlying reason or motivation, I think there's a real potential for ramping up expectations in families and then leaving them feeling betrayed and exploited when these sort of promised benefits don't materialize tomorrow afternoon. So I think we and journals, publishers and journalists and media should be trying to encourage a bit of humility and modesty in the claims that are made from people's research. And yes, there are lots of things that are fascinating and interesting and point the way or point a way forward that could be really helpful. But I think it's desperately important not to overpromise and then leave people distressed, which is what I see happening too often. Yeah.
I couldn't agree with you more. Absolutely. Great. Well, thank you very much for the interview. It's been fantastic talking to you.
Okay. Well, thank you very much. Thank you.